Good afternoon, everyone. Welcome to the January meeting of Plan Design. We're just letting everyone in the room. It looks pretty good. What do you think, Isabel?
1 second, I'm almost ready.
Okay.
We've got one person joining. There we go.
Good. Okay, great. Welcome everyone to the January meeting of the Plan Design and Expenditures Committee. Let's get started with the roll call.
Helen Belanca.
Here.
Shenwei Chi is not available. Peter Addy. Don't see Peter yet. Gabe Bandine.
That's me.
Thank you. Betsy Boyd Flynn.
I'm here, thank you.
Thank you. Mike Durbin.
I'm here.
Thank you. Rob Fizette. I do not see Rob. Tony German.
Good afternoon, present.
Thank you. Eve Gray. Thank you. Rosemary Hemmings let us know that she has a conflict today. Julianne Horner.
I'm here.
Thank you. Max Kaiser.
Here.
Thank you. Jim McGee is traveling today and might be able to join a little bit later. Peter Merritt.
Here.
Thank you. Angela McCallick. Don't see Angela. And Jamie Osborne.
Happy New Year, I'm here.
Thank you. That's everyone.
Great. Excellent. Let's start with some announcements and introductions. Is that you, Mimi?
I think that may have been a leftover bullet item. So we're just going to go right onto the agenda. I just was looking at that. I'm like, how did I leave that in there? Sorry.
Right, no problem. Okay, so quick agenda review. We're going to get an update, as we always do, from our executive director, Mimi McDonald, and then we're going to be talking with Milliman about some refinements to the cost estimates. And then we have 3 topics for consideration today. One is a draft proposal for payment model for specialty clinicians that we'll get a look at today. And if the committee feels ready to vote to send that to the board, we can do that. We're going to get an overview of some prescription drug payment issues that Lee will be doing that presentation. There's no vote on that today. That's just an informational presentation for the committee to consider. And then finally, we're going to be revising our behavioral health proposal. I should say the staff have been at work revising this based on a whole lot of feedback we got from this committee's original proposal. And we want to bring it back to you to have a little bit of further discussion and clarification on it. So we'll be looking at that again. And with that, I'll turn it over to Mimi for some updates.
All right, thank you. So good afternoon, everyone. Happy New Year, as Jamie said. I'm Mimi McDonald, Executive Director of the Universal Health Plan Governance Board. And just to catch up on some items that were sort of from the prior meeting. So one of the questions was about tiered pharmacy systems and cost sharing and potential for that. And we have an incredible presentation that Lee Hastings, Senior Policy Advisor, has put together, which will answer all of your, well, maybe not all, but most of your pharmacy questions and more. Again, that one is going to be informative, not necessarily any decisions to be made, but definitely keep in your head components that you would like to hold on to for a universal health plan. Status quo costs with HR1 changes was another question, and I'm going to transfer that one over to our Milliman compatriots. I know Ken Leskowski is on today to talk about their estimates and how, you know, if HR1 is built into the system, that maybe that will probably be an ongoing discussion. This is just some follow-up to cost containment. These are just for my notes. Eve is willing to help on some of our work with cost containment. Thank you. Today, we're going to get a lot into fee for service and value-based payments. So again, probably more information than anyone actually wants, but I think it will be useful, and I hope that it will be able to bring this committee together at least to make some provide a recommendations to the board for considerations of specialty payment. And then also at the end, just checking in, Jamie and Betsy said they're willing to help with some of our workforce analysis and discussion. We haven't started yet on that, so we've got them on deck, as it were. So any questions about that? Super, not seeing any. We'll go on to the next thing, which is, oh, and you can go to the next slide too. Talking about what's been happening at the board and at the other committee levels. So at our last board meeting, which was back in December, it seems a long time ago, the decision was made sort of around the regional footprint of the regions. We've already talked about what the regions might do, but this is really literally finding the outline of them, and there was an agreement upon that. There's a also agreement on what administrative structure would look like for a universal health plan, and ongoing discussion about revenue and taxes. That one is not ending. That is definitely coming up, especially in our next board meeting next week, if anyone has time to tune in. Our Community Engagement and Communications Committee, we're actually meeting with them. We're having a brief update meeting in January. With that group. And then there's also this, we've talked about this a lot, the targeted engagement meetings that Diana Bianco, our consultant, is putting together. So in January, in December, we met with Diana and really gave her an update about what all the different committees were up to, what the work plans were, and all the decisions made to date. In January, she's meeting with all of the co-chairs of the committees to really get together what questions remain to be answered and what would be the proper audiences for them. So that's the work that's going to happen with all of that work being finalized into actually starting to have the meetings in February and March. Operations Committee, always hard at work. Again, they were the ones who were working on the administrative structure with help from our Milliman consultant group. Have not completely finished with the enrollment proposal. So that is going to get finished up at this upcoming operations meeting. And then also for discussion about subrogation. So what to do when there is a third party payer, just say, for example, workman's comp, and how that all folds into a universal health plan. And then last but not least, our Finance and Revenue Committee. At the last meeting, they were introduced for the first time from our Milliman consultants, their actuarial analysis of estimates of total cost. That would be happen with a universal health plan, which is going to be very similar to the presentation that you are getting today. So I think it's going to be excellent, and I think it's going to be really helpful. Again, more work on the revenue plan. And then we had a terrific presentation from Jill Arena, who is a CEO of her own company that specializes in working with provider groups. So really got a great update on provider administrative costs and what are the components of a universal health plan that would specifically reduce administrative burden on provider groups. So that also was very informative. So let's see, I'll ask our board chair if I left anything out of that or anything else you wanted to add. Alrighty.
No, I think you covered it.
Sorry, a lot of fast talking. I know we have a lot to talk about today, so moving on. All right, I'm excited again to introduce, I believe Ken Leskowski is up on deck to present the refinements from the estimations for costs. So thanks, Ken, for being here.
Thanks for having me. Let's see, can you guys see my screen?
Yes.
Excellent. Okay, going right away then. Thanks for the introduction. Today you've got me rather than Fritz. So I hope I can do as good of a job as him and do him some justice here as I present to you today. As Mimi said, I don't know if anyone doubles up and goes to both the Finance and Revenue Committee meetings and this one as well, but it is the same content. It is the same slides that I'm going to be presenting between the two meetings. It's just some of the talking points, and I'm sure a lot of questions that you have will be different. And just right away to address, I think that initial question you had was, have we factored HR1 into our status quo? And the answer to that is yes. We consider HRL1. There's a number of impacts that we model between from even into 2026. So all of our starting base data is 2023, 2024. So we consider HR1 starting with 2026 and moving forward up until we get our 32 projection year. So the answer, I think that answers the question, but if it doesn't, just ask me again. And if since I'm doing double duty here, if anyone raises their hand, just
I'll call it out for you, Ken.
great, that'd be fantastic. Appreciate that. So once again, just want to start out with our same caveat slide that we always start out with, basically saying that these are estimates. We still are in draft format here. So getting right into the agenda, I'm going to start with a quick recap. Our estimates from the prior month are largely unchanged. Really what we're doing today and what's happening today is we're introducing more numbers. We're introducing admin, and we're just introducing some new concepts, some new scenario testing, and a lot of it's in theme with this cost containment and these cost containment levers. And I'll get into that a little bit as the presentation goes on. But just to get to our quick recap, if you recall, so way back in November, we started and we had our 78 to 90 billion range, which is with a 2030 valuation year and 4.7 million enrollees. So in December, the exact numbers I think were 73.7 billion to 87.0 billion was our low to high range, and that's going to be cost only, no admin at this point. And the major changes we made were moving to that 2032 valuation year and making some changes to our enrollees, changes to those non-resident workers. And we backed off a little bit on an adverse selection, how many people were assumed to move into Oregon as a result of adverse selection. And then we made a few refinements to our numbers, some of our base data. We did that study where we looked at capacity, and we lowered our induced utilization estimates a little bit. And we also removed LTSS. And just to address what I think is one open loop right now, we did not change that 73.7 and 87.0 remains the same, because we did all that we had removed from LTSS was that non-medical and non-drug component of it. So the medical and drug component of LTSS eligible individuals and those those services was still was appropriately in our estimates last month. So no changes were needed there, but I think that was one open loop. So now to get a little bit into.
Oops, I'm sorry, Ken. I'm going to say there's you put something in the chat. Could someone remind me how this compares to our estimate of what healthcare would cost under the current structure in 2030? So I think what she's getting at is like, where were we at compared to status quo? And I think you're going to come up to that, but I just wanted to make sure that we talked about that.
Is that relative to status quo? Yeah.
Yeah, Eve, will you clarify? That probably makes more sense.
Yeah, sure. Sorry, I'm finishing my lunch, so it just took me a minute to get back on camera here. So I am, I'm curious about, if nothing changed, and our employers still kept paying for health insurance premiums, and employees kept doing that, and we kept paying for Medicaid, and we kept having the dollars going into Medicare, and we kept having copays and deductibles and all of that volume of expense.
Yeah.
But in 2030, with inflation, how does this compare? Is this a more expensive model? Is it a less expensive model? Is it about equivocal? I think that's just something I want that finger in the wind to understand. Are we looking at a massive cost escalation here compared to what we would have expected as a system without this change?
Yeah, and a great question. You already asking some of the same questions they asked on Tuesday for me, so making it easy for me. But so I'll refer you back to table 3 from our prior from the December presentation. So the directly comparable number to that 73.7 and the 87.0 are these 66.6 and the 70 to 76 billion range for status quo. And those are on a 2032 basis, just to be clear. So a couple of just things to keep in mind as you view these numbers. That status quo number doesn't have the admin layered on. I can get you status quo admin numbers if you think that would help. Just to describe some of the main drivers. So this isn't partition. The status quo and these numbers are in aggregate. They're in total. So we don't have. Part of this is dental, like the dental and the PEB Plus package. The dental, vision, and fertility costs are a lot higher in the UHP estimate. So that's one of the drivers of the difference between the status quo and the UHP, as well as just everything else that goes into our cost modeling. I see another hand up as well.
Yeah, Tony.
Yeah, thanks, Ken. Sorry, I'm off camera because my internet's a little unstable here. You just mentioned something that I wanted to clarify. You said admin is not included in these figures?
Yeah, these figures that you're looking at right here in table 3 do not have admin layered on.
Which is, if I can interrupt, that's what we're adding on today. So the first thing that Milliman did is just figure out pure healthcare expenditures. What are we paying for benefits? And then as a second analysis, they looked at admin, and that's what he's getting to today. We're putting that in today.
Yes.
Okay. That's helpful because it just seems like we're looking at total cost of care is what we're looking at. We're asking a question, what is total cost of care, total spending? To give that information for finance and revenues. Isn't that this exercise?
Right. So, we need to come up with a total estimated expenditure amount, right, and try to reconcile that with the revenue strategy. And Angela, I see your question in the chat too. Ken, jump in here, but it is not just claims. This is all money paid for healthcare. So it includes out-of-pocket costs. It includes copays and coinsurance that people have also paid. So it's all of the money that goes to providing direct services minus the admin at this point.
Correct. That's accurate.
And roughly 71 billion for status quo and 81 billion to do the universal health plan, because we're covering more people. We're giving people a richer benefit package.
Yes.
And then we have a little bit of induced utilization where people will be using more services than they would under status quo because of the ease, in theory, the ease of accessing that care.
Correct.
Okay. Thank you. And just another, when we are putting into the equation the assumptions made, Ken, I was curious about, there have been some studies and research, and our hypothesis in moving this is that there are going to be greater efficiencies in the system and a reduction with admin and some of those. So I just wonder how those are calculated. And I think I've asked this in some flavors in the past 2 months, but how are we putting those assumptions into this analysis?
So in terms of efficiencies toward total admin, and this is admin from a payer payer perspective, the admin, so these estimates, the admin estimates I'm going to show briefly, all come from our Milliman team that's supporting the operations committee, and they do include some administrative efficiencies in their estimates that would happen as a result of the single payer system.
Yeah, I'll just jump into Tony. If you want to listen to the presentation at Finance and Revenue from Tuesday this week, Jill Arena gave a really great overview of the anticipated efficiencies that would be gained under Universal Health Plan. She goes through that pretty well. So yeah, that's another resource. Yes, we are considering the efficiencies.
Thank you. That's helpful. And I'll refer to that. And it sounds like they are incorporated into these figures.
Yeah, we have a little bit of a artificial separation in this work because obviously it's all connected, but just we had to divvy up some tasks. So we put administrative costs, like what's the administrative structure of the plan? What are the administrative costs of the plan? We put that with the operations committee. We're trying to divvy the work up but we have to pull it all together. But really, we're not really considering administrative efficiencies as part of this committee's deliverables. It's really with operations. But yes, eventually it'll pull all together.
Fair enough, Helen. I have some cautions on it. I just feel like, the question remains is total cost of care, and admin just seems to be a part of the calculation that we're trying to accomplish here. So I get what you're doing. Let's carry on. Sorry.
All right, no other questions. All right, let's get back to the additions and the new concepts that we're introducing here in January. So in the past, we presented just a range, a low to high range. We're now going to include a best estimate number alongside that low to high range. As discussed, we'll add layer on administrative costs. And then we've introduced a couple of alternate scenarios, a linear benefit design, and also the UHP cost if we were to exclude all Medicare eligible individuals. So that includes anyone who's a dual eligible. And the reasoning behind this is there's a couple of reasons, really. It's flat out, it's part of our engagement and part of our responsibility for what we need to tell all of you is we said we would model at least 2 plans for you. And if the initial plan we have is the full benefits with the full population, the only place to go is a little bit leaner. So we have a little bit leaner plan design, but this also goes hand in hand with last month we talked about our cost containment levers. We have those 6 cost containment levers, eligibility, medical management, pharmacy management, and then benefits and cost sharing. And maybe I missed one on that list. Provider reimbursement. So these go hand in hand with just communicating, what are the available cost containment levers, and how much do they save, or for lack of a better word, how much do they lower costs? So just again, giving as much information as you have can get, and so that we're giving you everything that we said we would provide you. And I think it's very fascinating too, and I think you'll find it all helpful and interesting. So I want to get a little bit more into this this lean plan, this full benefit plan. So just as a reminder, everyone here is aware of the full benefits plan. There's no cost sharing. And the PEB plus benefits are included, and those PEB plus benefits are those the dental, vision, fertility, and then a few other minor benefits that are less of cost drivers than those 3 main ones. So for this second plan, what we're referring to here as a lean benefits option, it's not just a caveat here. The first thing we're doing is we're removing the PEB plus benefits. So again, that dental, vision, fertility. So that's really what's making it the lean benefit version. In terms of how we think of a plan as actuaries, it's still a very, very rich plan compared to anything you may get from commercial market or even Medicare. Really, only Medicaid would be the one that pays out more. So we've chosen these cost sharing here with not really with the idea of generating money for the state, getting money back, but more in those concepts we've discussed before of that driving decision making. So how are we influencing the people of Oregon to make proper decisions that help you save costs? So when we think about that, we think of ER and RX as the two main drivers. So we put a $200 copay on ER. And then for now, we've just put a 3-tier prescription drug system where it's a $5 generic copay, $75 all brands, and $150 on all specialty drugs copay, with the idea that we're driving people to choose the generic option when it's available. And there was a question Tuesday that I'll answer in case anyone has it on their mind real quick here. The idea of it is steerage. The idea of it is to get people to choose a generic equivalent when there is a brand. But even if there's not a generic equivalent on a specialty drug, for the purposes of this modeling, they're still going to have to pay a $150 copay. That's just the easiest way to model this right now. And we've also put a $1,250 member maximum out of pocket. And these are roughly based on the current PEB plan options with a little bit of trend for inflation. And I see Helen, you have a question?
Yeah, I just wanted to clarify for the committee, this committee started, or the board started calling it PEB Plus, and the plus refers to enhanced behavioral health services. And I just want to clarify that in this lean benefit plan, the behavioral health services are not going away. That's not part of what's excluded.
Yeah.
The benefits that we're excluding from this plan are vision, dental, and fertility services. Is that right, Ken? Did I miss anything?
Yeah, and some other minor things like sleep studies that are.
Oh yeah, sleep study. Yeah, but it's nothing about behavioral health. So those are current, like actual, like real PEB benefits, right? So it's just a few of the more expensive of the PEB plan benefits. But what we call PEB Plus, the plus is for behavioral health, and that's not being excluded.
Yeah, thanks for that clarification. That's all correct. Yeah. And just as a little note on the bottom there, because this plan is a little bit leaner, there is we do make an adjustment for induced utilization. It is slightly lower. I'll see in the chat, what are some examples of drugs that fall under specialty under this model? Those are going to be your very high cost drugs that are utilized by only a very small population of people. Things like your Hep C drugs.
Monoclonal antibodies, like the new immune-based therapies for cancers and stuff like that are like tens of thousands of dollars.
Yeah, correct. All right. So I want to get right into the brass tacks of it here. Want to start getting some numbers in front of you. And on this slide is where I'm going to start to transition into admin. And I'll give you a visual of the total amount of admin on the next slide. But getting back to our December results, we had this 73.7 to 87.0 billion. That's without admin. And so we're going to introduce this, that results in 80.3 billion best estimate. And then when we layer on the admin, we then get an 85.5 billion best estimate for full benefits. So I'm going to start to draw you towards that 85.5 and that 78.5 billion in the lean benefit option, just to narrow the focus because we are providing a lot of numbers in an effort of transparency. But I think these are two good places to narrow your focus. So to get a little bit more detail, that results in a low to high range of 77 to 94 billion for the full benefits, and 71 to 86 billion on the lean benefits. And again, to look at the detail here, that consists of major benefits, which are medical and drug benefits, what we call the PEB Plus, which is really that the dental, vision, and fertility. So you can see in the lean, we've zeroed that out, that dental, vision, and fertility. And then there's this cost sharing. So what this column C, this cost sharing assumes is that of this approximately 74.6 billion, the state will collect back about 1.2 billion from those copays. That assumes 100% collectability here. And then in column D, we've layered on those administrative costs, which do also have a range on them from 3.6 to 7 billion. The administrative team was not within scope to really do a second set of administrative costs for the lean benefit scenario. You can assume it would be slightly different, possibly because of the administration required to collect those copays. But for now, we've just layered that same cost on between the full and lean scenarios to give us those total costs.
Did that get to your question, Jamie? Jamie, that was exactly Jamie's question, I think, in the chat. You know, why would admin costs be the same? But I think that you kind of answered that, because they just, yeah, thank you.
Yeah, exactly. So it's the same thing with not only the collection of the copays, but also with dental and vision. Yes, theoretically, you can assume that maybe the administrative costs might be a little bit higher, but that's also why we provide a range on the admin as well. You can maybe visualize that higher range in the lean benefit scenario more so than the low range. All right.
And then Tony has his hand up.
Yes.
Yeah, okay, so just to clarify, I think what I heard you say is that you guys don't foresee with collection of cost sharing that administrative cost would go up in these two scenarios?
I wouldn't phrase it that way. It may go up. Administrative costs may go up as a result of collecting those copays. We just didn't model it. We just don't have a second set of estimates to include it. So I lean more towards the higher range on that administrative cost for the lean benefit scenario.
Yeah, I mean, I think it's safe to assume that if you have to do more work, both on the provider side and on the payer side, as far as tracking copays of that nature, that I think it's safe to say that those would go up. And it looks like the model, as far as the administrative costs that you're projecting, at least if we just start at the full benefits, that's about 5.2%, and then in full benefits, I think it goes up to about 8% and change, right? So anywhere in the total cost of this system, you guys are projecting administrative to be from 6 to 8% of the total cost of care.
I don't. Is that?
Yeah, if you just do 3.6, divided by 69, right? Or I guess actually it would be a little bit more, because it should be 72.
If you're okay with this, I have actually the slide pulled up that kind of goes over that. Would that be worth sharing the screen, Ken, just for a second?
Yeah, sure.
Okay.
Do you want me to stop sharing here? Also caveat that I did not create the administrative costs.
Yeah. So sorry, this is a little Frankensteinian here, people, but so apologies to the other amazing Milliman team. But I think kind of the math you were getting at, Tony, is right here at the bottom. Estimated admin costs percentage of total UHP expense, excuse me. And again, this is the administrative costs of the plan, just so you know, the highly efficient was at 3.8, less efficient at 7.1. And this is part of the presentation that I said I'll ask Isabel, and we'll get it posted with all of this meeting's materials too, so you guys have a much more detailed analysis, because they certainly went into that a little bit, or a lot, excuse me. So hoping that is helpful. And just so people get an average, most health plans, their administrative costs run between 10 to 20%. So this is a huge efficiency on the part of for a universal health plan. So I just tossed that out there too.
Mimi, isn't it true too that Medicare is lauded as like the best sort of example of low administrative costs, and they run at like 4%, right?
Correct.
Yes.
Yeah.
Medicare.
Yeah.
All right. Here, I'm going to stop sharing and go back. So thank you. Sorry, I just thought.
Thanks, Mimi.
Sure.
Mm-hmm. Just a couple quick notes on what Mimi shared. That was
sorry.
Those were 2026. That's just how they worked with that committee and how they did it. At this point, we have now shifted to 2032. So if I reshare my screen.
And sorry, just one quick question. So you
Yeah.
guys, Milliman did not calculate the administrative, or you guys did?
Milliman calculated it. We have a separate team, Stephanie and Kate and John and others that are working with the operations committee. So Fritz and I specifically did not calculate it. That team did.
Okay, thank you.
Yep.
And then, sorry, just one more, Ken. Angela had the question, is this comparable to MLR targets? And I think it just sort of, maybe, do you want to say a little bit more about that, Angela?
I think kind of speaking to where you about the health plan, 10 to 20%, I was like, oh, that's pretty much what MLR targets are, the requirements.
Thanks.
Yeah.
Okay, back to you, Ken.
All right. All right. So next, want to introduce this idea of just helping you understand how much of this cost is Medicare versus non-Medicare eligible. So we're going back in time a little bit, so I don't want to spend too much time here because I want to start thinking in the context of only having the admin layer on. But we're going back to our 2032 total cost estimates, that 73.7 to the 87 from earlier, and just to show you how much of this is contributed by Medicare eligibles versus non-Medicare eligibles. And so we are projecting about 40% of costs are due to Medicare eligibles versus only about 25% of the population. So it is a big difference. It is a large portion of the population, and a lot of that's attributed to Oregon's very aging population. So on the next slide, just to then take our same step as earlier and layer that admin onto that non-Medicare eligible population. We come up with a new set of best estimates for the non-Medicare scenario and a new set of ranges. So we're really looking at that 52 billion best estimate and that 47.7 billion best estimate with the ranges that you can see before you. I'm going to keep going if there are no other questions. So this slide, there's no new information in this slide. All these numbers have been shown on previous slides, but we wanted to have one slide where you can see that total all-in cost number, including admin for the full benefits, the lean benefits, the including Medicare and excluding Medicare population, all in one place. So as we've done in the past couple of months, we'd like to.
Sorry, Ken, I'm going to interrupt. Betsy has her hand raised.
Sure.
Mimi, just a quick question. Is our group the group that would make sort of decisions about whether or not to include Medicare eligible folks or not? And I asked the question because my actual question is, if we didn't try to include Medicare eligible folks, do we have any sense of whether that would make this easier or harder to get federal approval for?
Well, I have answers for both of those. So yes, this is plan, design, and expenditure, and yes, sort of making recommendations. Well, let's see. Now I'm getting a little bit befuddled. Operations really did more of the eligibility things.
Mimi, I can.
Yeah, thank you.
So this committee's role is to make recommendations to the board, and the board will ultimately decide if who's covered, under what circumstances, and which waivers we apply for. So we've gotten many Medicaid waivers over the years, as you all know. Medicare waivers are a very different story. A Medicare, in 1970s, Maryland got a Medicare waiver. Vermont was granted one when they were, exploring universal health care that was never utilized because that plan fell through. But it's really, really difficult to get a Medicare waiver, and it would come with its own level of administrative burdens. Medicare is entirely federally run. I know you all know that, but the state wouldn't have any sort of leeway. The federal government would want to control how that waiver was implemented. So the administrative burden of getting a Medicare waiver to do a universal health plan would be a whole nother scenario. So the answer is we don't know how hard or easy it would be to get a Medicare waiver. What we know is that it's been almost never done, right? And so, but if we did, it would add another layer of complications. And we just need to build in some strategies for, a possible delay, right? So getting those waivers, we don't get to control the timeline of those waivers. And so we need to have a scenario in which the waivers come much later than we expected for both Medicaid and Medicare, but certainly for Medicare. I think a Medicaid waiver is a little bit more sort of doable, so to speak. Those are much more easy. But so what we want this committee to do is give a recommendation to the board. As Ken mentioned earlier, we've never had the idea that it would just be like sort of one plan. We want to give options to the legislature of here's what you asked us to do, here's what single payer looks like, covering everybody with one fund, and then at least one other option we want to give. And so what we're debating right now and thinking about is what would that alternative option look like, sort of to compare and give the legislature some choices. So this committee could recommend to the board that we do something like lean benefits, but keep covering everybody. We could say we want the full benefits, but maybe let's exclude Medicare. There's no reason why you couldn't, suggest both alternatives and show the numbers for both and let the legislature decide. These are Ken just kind of going through what are the options that we've thought of as sort of an alternative to that full plan.
Yeah, exactly. That's all very well. What I'll also add on from the lean benefit plan perspective, we put in that $575, $150 copay. Just again for steerage and based on what we saw in some of the PAB plans as an option. There's really at this point a large number of options, a large number of things you could do with a lean benefits option. Those copays could be anywhere, but I think it's a good starting point to generate your discussion. So yeah, as we've done in prior months, we've tried to reconcile back to that Optimus report just to help everyone understand what kind of the changes that have been made, really the differences in the way that they did their valuation and the difference between how we did ours and really what's changed since they did it. So we have this waterfall graph here to kind of help with that. And that Optimus 2026 number there is that 55.6 billion. So that is their estimate of 2026 UHP expenditures, including that admin. So just moving to that 2032 valuation year, starting year, increases the cost by about 22 billion, and that's using the Optimus trend estimate number. And so that's a mix of changes in population and that trend number. And then our estimate for induced utilization is about 1.5 billion higher. Our estimate of that dental, vision, fertility component is both our dental is higher, and I don't think Optimus. Someone correct me if I'm wrong, but I don't think Optimus explicitly called out the fertility or vision amounts.
They didn't.
Then our estimate for uninsured is about $1 billion higher. That one's kind of just a moving target, and HR1 has a little bit to do with that in the projection. The Optimus report didn't include the anti-selection, that adverse selection component that we have, and then there's just general. We kind of put everything else into this other miscellaneous bucket, but it's we have a different starting point. Like they. I think the data they had to start with and use was 2019 data, and so we're a few years in the future. That changes things, and then we have slightly different assumptions. Again, 4 more years of data to kind of tweak and change our assumptions, which adds another $1 billion. So that gets to back to that 85.5 billion number, which is the subtotal for full benefits. And again, we're starting to transition into this, showing you all the different cost saving scenarios or cost containment scenarios. So a change to the lean benefits would result in about $7 billion less to get to 78.5, and then excluding Medicare from that lean plan would be another $31 billion reduction. So are there any questions at this point?
Ken, I'll just, I know that not everybody on this committee has been a fan base of this work since 2019. So just if you're not familiar with what we're referring to with Optimus, the task force on universal care met from 2019 to 2023 in that range. And they did all the foundational work for our board. And Optimus was an economic consulting firm that they used to get a rough estimate on the financial feasibility of a universal health plan. And one reason why we keep doing comparisons to Optimus is because in the task force final report, what they said is that if we offer universal care to everyone, we could cover everybody and save $1 billion over what we currently spend. And I think what Ken is trying to outline here is sort of all the reasons why their estimate wasn't exactly quite the same as the one that Milliman's using, and sort of explain why our estimate came out as costing more. So according to Milliman, if we cover everybody with this enhanced level of benefits, it will actually cost more than the status quo, whereas Optimus predicted it would cost less. And I think this graph does a nice job of sort of outlining where those discrepancies are.
Yeah, and I think this graph is also of a particular use to the Finance and Revenue Committee as well. I think they've done a lot of their work referencing that Optimus report. There's a couple hands up.
Yeah, I think Eve is first.
I'm just wondering, and here we are, maybe a Medicare waiver again, but would it be doable, assuming if folks were to transition from even the lean benefits in this plan to Medicare, they would probably have some significant increases in out-of-pocket costs at a time when their healthcare utilization is going to go up in their lives. Would there be some possibility to budget in, like I'm sure you couldn't do a healthcare savings account legally, but something where the state could help provide a sum of money to support that out-of-pocket that they would be experiencing in prescription coverage and copays for other reasons in order to soften that blow. It obviously would increase the cost overall to the state, but I feel like it would be more in the spirit of what our goals were and having everyone have as equal coverage as possible.
I mean, I would say, so if I'm understanding you right, like if we went with lean benefits and then people transitioned from the universal health plan to Medicare, which would be, if we excluded Medicare, that the one problem would be the big jump in out-of-pocket costs. I mean, certainly that's something we could recommend. I mean, I don't know that we would build it into our cost estimates right now, but I think it's a really important thing to think about if we did exclude Medicare, that there would be that significant jump, and that we might offer, that as a possible strategy, like you said, to soften it. But I don't think it doesn't seem like including it now it'd be a really hard thing to estimate right now.
Tony.
Yeah, thanks, Ken. Very thorough with this, and I just wanted to clarify the trend to 2032 and what 22 million billions equates to. That correct me if I'm wrong, that is also 6 years of time. That is a difference maker that goes into the equation. That's inflation. That's impact of HR1. Is that what's falling into that second category?
Yeah, so it's if you take the 55.6 billion, it's that 22 billion is actually fairly simple conceptually. It's if you take the 55.6 billion, we use the optimist trend, which is 5.7%. So you multiply it by 1.057 to the 6th power, and then also it's a little bit more nuanced and complicated that we didn't just do straight up 1.057. We only did it to appropriate costs, and we trended dental a little bit different. But as a pure conceptual basis, that's pretty much what we're doing. Just taking medical cost, trending them 5.7%, and also factoring in the population increase.
1.0 what you said?
5.7%.
Yeah, per year. So I mean, that just seems like that.
Yes.
Yeah, I mean, if we were to calculate this out to 2050, you would times it by 5.5%. It sounds like, right? But I guess what I'm getting at is that's a matter of years, right? So I guess back to Eve's question at the very front of this is what would be the existing cost structure in the present system comparatively? Because I think it's really important to make this distinction of what would be the system in the future, and are we blowing past that, right? That's a really important distinction, I think, for us to make here. What I'm seeing here is that I think that is related to inflation and to years of a trend, but really the increase in cost to the system we're saying is this 1.5, 2.2, covering the uninsured, the anti-selection, and I'm not starting point. That piece I wasn't directly following. Can you help us with that?
Yeah, so if I go back just a couple slides here, let me know if this helps you. Where do we keep going? Just getting back to these administrative costs. So that 3.6 up to 7.0 range. Our 2032 status quo prior to admin was 66.6 to 76.2. So there are of course going to be differences. Like it's because of the savings of the single payer system. It's using that 3.6 to 7 isn't totally appropriate. But if just for your example, and to help you understand, if we do use the 3.6 to 7, that's going to be about 70 to about 83 billion. So really, you're looking at a best estimate of 86.5 billion. And so to bring that back here, I'm sorry, 76.5 billion. So it's okay. It's okay to check my math live on the call. So that 76.5 billion is going to be comparable to this 85.5. Does that help?
Yeah, I apologize. I'm not fully tracking this, I think, in this, but that's okay. one observation, I think, Helen, I'm curious, is that I think this is exactly the question of where I wish we were like a year ago, to put dollars in front of us and now get into the nitty-gritty of what we can afford. And I see this exercise of saying, can we afford Medicaid? Can we afford these different items? I do wonder, I was kind of curious about, we had talked about this in earlier meetings, probably about a year ago, of helping support the work of our committees to work with finance and revenue, of a little bit of a back and forth and getting information from actuaries, say, well, here's what this is. What happens if we pulled this out, or what we put this in? Because I really think the what it comes down to is, what can we afford? Like, we're all sitting at the dinner table, we have our budget, and we're figuring out what can we put into the system and what's going to work. And I wonder about the conversation that is envisioned still, or thinking through that, because these are, I would hope that, that this committee could contribute to that, and the finance and revenue with that, to come up with a plan that is supported, that still meets our communities and our population, and to get good health outcomes. But obviously this is we're talking about scarcity, and that's been the whole issue with healthcare, and figuring out how we ration it. And we're trying to do it in an equitable fashion with universal care, but it's still going to have some limitations. So I think that this entrance of cost sharing, it gives me concern, but I understand it. Right. And that conversation. So I guess my question is how the finance and revenue, and how, perhaps our group, with how we can support the board, because these are tougher decisions, and having the input. I don't know. Long-winded question.
Yeah.
How can we support the board?
Right. Right. And so that work is happening right now. This is the slides you're seeing in front of you as a result of that work, of starting to think through, what could we take out? What makes sense? How do we reconcile these expenditure numbers with our revenue strategy? That work is going on right now. We have frequent discussions at the committee chair level and the staff level about what's happening in finance and revenue. Many of us are going to both of those meetings, and just trying to see, like, what are they saying? What are we saying? How can we reconcile it? When this board was convened, we had a different executive director, we had different staff, and our former executive director pitched the idea of joint meetings between plan, design, and expenditures, and finance and revenue. When our new executive director came on, Mimi, we had to revamp the workflow. We had to reassess where the committees were. We had to get a better handle on the work involved and the consultants that we were dealing with. We had a lot of plans like a year and a half ago when this board started that have since had to be modified for time reasons, for logistic reasons, for all kinds of reasons. And so, yes, it's true that in the very beginning of our work, we pitched the idea that we would have these joint meetings between finance and revenue and plan design. That is not feasible. We, aside from the logistics of trying to get all of those people together on the same day at the same time, that's a really complicated thing. But all of you have been engaged in some very detailed conversations about how we get to this place. And finance and revenue have had very detailed conversations about how they got to their strategy. Just to put everyone in the room, we would spend 3 or 4 hours just getting everybody up to speed on just where we are with what decisions, and then trying to parse through them. Just the task is pretty giant. And so what we've decided to do, what we are doing, is that the board members that are part of each committee, and the staff members and the chairs of the committees are constantly talking with our consultants. We're going back and forth. What we need from this committee is your best recommendation for how to approach expenditures. If we needed to reduce our expenditures, sort of what would be your preference? Would it be to go more for a lean benefit and have some copays? Would it be to think about maybe excluding the Medicare population, at least at first? We obviously are going to put together a plan where it includes everything and just show covering everybody for all these benefits. Here's what it'll cost. And then, like I said, we just need some alternatives. It is not the role of this committee to make any decisions. It's the role of this committee to make some recommendations to the board, and then the board and the staff will have to reconcile all those recommendations and make them fit. And so what the board comes up with ultimately may not look like what either of the committees sort of decided, but it'll be our best attempt at reconciling what the committees have recommended to us. So what we need from you today is sort of ballparking where this would go if we needed to make some cuts. I'm aware of the time. We're getting pretty behind on our agenda. I'm going to let Ken finish, and then we can see we can move on to our next agenda item, and then keep talking about this after that.
Wait, Eve does have her hand up.
Okay. Sorry, I can't see.
Yeah, I know. That's why I called her.
You're all trying to be quick. I think I would favor that we have a little more conversation about what lean benefits look like if we were to recommend lean benefits. I mean, this is one example of how they could look, and I really appreciate that example. I do think that there are opportunities for us to take a look at medicine that maybe is not always evidence-based. So when you have particular procedures where physical therapy is often as effective if done over sometimes a longer period of time compared to a surgery, those are areas we could actually have some quality oversight to pick places to add cost sharing that add value to the system in order to help drive choice. So I think I would want to massage that a little bit more, but I personally do believe that if everything is completely free, regardless of whether it's the right thing to do, it will drive up health costs in our system. So I suspect that we need to take a look at this more carefully.
Yeah, I totally agree with you, Eve. And what you're getting at, we're going to speak to in a little bit about the specialty care proposal, because a lot of that comes under specialty care work and some value-based care work. And that is a place where value-based care really does have something to offer there when we try to eliminate low-value care, is how I would frame that, eliminating low-value care. And there are some opportunities for that. And that's going to be part of our recommendations on our quality oversight regardless. That was part of Mimi's presentation on our quality proposal. I think when we talked about making lean benefits, we went for low-hanging fruit, which is it's super easy to extract dental and vision because they operate on these totally separate wavelengths. And then fertility is always sort of a carve out that some plans pay for and some don't. So we went with low-hanging fruit, but you're right, we could we could make the recommendation, for instance, to the board that consider lean benefits, but focus more on low value care, or, however you wanted to frame it in terms of reducing costs. Yeah.
Okay, I'm going to keep going here. So next on the layout are 5 and 10-year projections. I am going to go through these slides maybe a little bit quick. Unless if someone would like to ask questions or spend more detail. The reality with a 5-year and 10-year projection is, now we're getting out to 2037 and 2042. So the uncertainty just increases and increases. So what I think is most important for you guys to know is, this is here. These numbers it's again, the same scenarios. All this information is here for you to look at for both 2037 and 2042. We can quick go. This is probably the most important, which is explaining how we did it. And we're not fortune tellers here, so just it's a few simple assumptions here to develop those 2032, 2042 projections. So we're using those same trends that we use to project from 26 to 32, which is just as a reminder. The source that we use to do that's based on Oregon specific and national health expenditure data. And so for the low range, we use 5.3%, and the high trend, we use 7.4%. And we're using a flat 3.0 dental trend, which is based on some internal Millman research. And we're using a flat 3.0% on administrative costs in total. Population growth is based on a 0.45% increase, and that's just the average increase between 2024 and 2032 based on the Oregon Office of Economic Analysis. And finally, we did put a small amount of pent-up demand on just that previously uninsured population in 2032. and we wind that down within 4 years. It doesn't make a huge difference because it was only that pent up demand was only going on the previously uninsured. It wasn't going on anyone that already had insurance, but that gets wound down. But feel free to email me questions if you have anything. I can go through this. So we've talked about provider reimbursement. Fritz and I were kind of talking after the last meeting, and just having a conversation out loud. We thought this would be helpful to show this committee. So we just took we looked at a couple of what we call similar states, states that have similar approaches to healthcare, similar kind of government situations, and decided to compare them because we talked about provider reimbursement as a potential cost savings lever. The issue and the reality of provider reimbursement as a lever is that if you cut provider reimbursements, then you might have provider exits, then you might have reduced access. So one of the, I guess, kind of challenges that Oregon faces is that relative to these other states, what that graph on the left is showing is that Oregon has a much lower percentage of its population in the commercial market compared to the Medicaid and Medicare markets. And the commercial market is where reimbursements are higher. So we just did a real quick study where we said, hey, if we assume that every state pays Medicaid reimbursements at 88% of Medicare, what is the difference in total aggregate reimbursement in state? And just because of the mix of the population of Oregon, Oregon provider reimbursements are a good 4 to 10% lower than these comparison states. So that just makes the challenge of using provider reimbursements as one of these levers much greater. So again, to remind you, we have our 6 cost containment levers. You've seen this last month, so I'm not going to go over it in detail, but we just wanted to get all of these cost containment measures that we've been talking about, again, in one place for you to reference. So the eligibility going from what happens if you just take, if you remove the Medicare population in both the full and lean plan, what happens if you go from that full to lean as the benefit reduction and cost sharing are combined in that situation. So what is the total cost savings? And then provider reimbursement, medical management, and pharmacy I want to talk about real quick, just so you understand the context these are in. So provider reimbursement, this number is just assuming a 1% reduction in overall provider reimbursements. So this wouldn't impact, for example, pharmacy. It wouldn't impact a few. It's just pure providers get 1% less than they're currently getting, and this is all on a 2032 basis, I should say, as well. And then medical management pharmacy, again, just to give you a number to work with, if there's a 1% decrease in cost resulting from medical management initiatives, Fritz, this is the savings range you can expect, and Fritz had kind of spoke about how the realistic range of medical management is everybody's within that 10%. So just to give you an idea of what 1% is, that's here in this table, and same with pharmacy. If there's a 1% reduction in pharmacy costs as a result of pharmacy management or something with rebates or some other initiative, what would that actually save? How much would that actually lower costs? And I think that's all of the content that I have prepared for today. I do have some next steps in here because our final report, our final actuarial report is due to you in February. So if there's any more feedback, please send it to us. Are there any other questions? All right, thanks for having me again.
Thank you so much, Ken. We really appreciate you being here and for all this work.
Thanks for having us help. It's been a lot of fun. Good luck.
All right. I am going to present here sort of I will go relatively quickly through the presentation that I put together. You all should be grateful that Lee Hastings took a look at it ahead of time too. So a lot of slides are already gone. It's already the lean-ish version, but we will go through this. This committee we have talked a lot about how providers are paid. So I think there are a lot of things that we can move through quickly, but what I want to get to is the specifics about specialty care. So if I can have the next slide. Really quickly, what is specialty care? How does the US stack up against other countries? What type of money, what are we talking about here? Is this a tiny amount? Is it a huge amount compared to other costs? Currently, what are the payment systems? What would be a great specialty care payment model? What do we want in that? And then finally, some recommendations. So next slide. I think this group knows what specialty care. It is not primary care. So health services that focus on a specific area of medicine or group of patients with specific types of systems. Specialty care providers can address acute or chronic changes. Cardiology, orthopedic surgery, oncology, psychiatry are all examples of specialty care. I'm an OBGYN, which sort of falls in a weird middle group of primary care, specialty care. Psychiatry sort of falls in that liminal space as well. And sometimes they are compensated as primary care and sometimes as specialty care. But next slide. All right, so in terms of the US, and I'm just going to look at just cover your eyes about the how few practicing psychologists and psychiatrists there are in the United States, because it's a little bit depressing. But if you look at this, and I apologize, because of course there are lots of types of providers. This happens to be physicians. So in the US, we have fewer physicians per capita than our peer nations. We have far fewer percentage of them who are practicing primary care providers. So therefore, of the providers that are in the United States, a larger component provide specialty care. I did have to do a little shout out to Canada for having all of those behavioral health social workers. It's pretty impressive. All right, next slide. Now, this one, what I wanted to get our heads around is like, well, is it just way more expensive in the United States, or are we doing a whole bunch more angioplasty? Are we doing way more CABGs, more hips and knees? So this is an important caveat, though. This table that I got from KFF is really only looking at inpatient procedures. So, which of course, so is excluding all the procedures that are done in ASCs, ambulatory surgical centers. So what I would like us to look at, and I'll just go through this one a little bit more slowly, is if we look at the cost, and public insurance here is referring to the cost that Medicare would pay versus the cost of private insurance in the United States, and this is how much that will pay, and then in comparable countries. So let's just look at angioplasty on the top line there. Medicare pays about $17,000. Yeah, private insurance company would pay about twice that. And these other countries, it's about $5,000. And you will notice that the trend continues. If you get a coronary artery bypass graft, also known as a CABG, on Medicare, it's $44,000. Other people's health insurance would pay $90,000. Again, and these are comparable countries, $24,000. And we can just kind of go down the list. There is always substantially. So what I'm getting at is, no surprise to anyone, but it truly does cost more. It's not necessarily that the United States has much higher rates of utilization for these procedures. And then if we go on to the next slide, and again, this data is a little trickier than you might anticipate, being harder to get than you would anticipate. So I had to pull it from a couple of different sources. But if we look at the rates of, again, angioplasties in the US, higher than other countries, but not like crazy higher, and it is projected to go up in the United States. Knee replacements, and this is interesting because I think lots of times when we talk about, people will talk about, oh, in Canada, you have to wait so much longer, and obviously this is multiple countries, but rates are about the same, or utilization, and the same thing, hips, actually, this again was a little bit of a surprise to me. but hip replacements potentially even a little bit lower than other countries. So again, it is not necessarily that we are doing so many more procedures. It is more that they are costing a lot more, which is driving up the cost in our country. And I think it's really important when we think about that for specialty care. So next slide, please. And you guys put up a hand or anything if you have any questions. Otherwise, I'm going to be rolling through this pretty quickly. This is from the terrific Sustainable Healthcare Cost Growth Target Report from Oregon. And you can just see going from 2022 to 2023, the increased Oregon healthcare cost trends in billions. And so you look, hospital inpatient goes up, outpatient goes up, professional fees going up. It is all going up and continuing to expand. So when we think about that trend, if you think about going from the, what was it, the 2026 data to 2032 data, you can see how that healthcare trend just increases so extremely. And at this point, there is not a evidence on the horizon of any significant trend that it will be turning in the other direction, unfortunately. So next slide. Thank you. All right, specialty care payment models, vast majority of the time, specialty care is paid fee for service, so providers paid for each specific service or the procedure. There are value-based payments in specialty care, and I am going to talk about a couple of the different models. There's an episode bundled based care. So for example, you get a hip, and so this would include pre-op time to post-op time and everything in between. That's the amount of payment that a provider is given. There's also specialty specific models that we'll get into. And then there's the bigger one, like accountable care organizations that we've talked about, population based. And then there are also, and pay for performance can mean a lot of different things, but usually it is related to a quality metric in and of itself. So we'll go into that, and which is actually fairly common within specialty care, but not, well, we'll get into the thoughts about that. Okay, next slide. Again, thanks for sticking with me, everyone. I know we're going fast. So this talks about fee-for-service participation. Again, surprising no one. Plastic surgery, actually surprising that it's not even higher than that for fee-for-service. You will notice that pediatrics, family medicine, and internal medicine have not zero, but less fee-for-service participation. So as I said, specialty care utilizes it the most. Next slide. Okay. I would love to go into a lot of detail, but I don't think that we can do this. But what this is, I hope people have a chance to look into this a little bit later. It is the physician fee schedule, which is essentially the decisions that are made at the federal level about how much money CMS will pay. And almost all fee schedules are built from that. Many of you are aware of what are called RVUs, or relative value units. And those are what payment schedules are based upon. RVUs are actually, I think it's interesting, they are built on three things. There's the provider work that goes into it, practice expense, and they also factor into malpractice liability. Again, being an OBGYN, that was higher than some other specialties. There's a geographic practice cost indices that is a factor into that RVU payment. And then there's a conversion factor, which converts RVUs into dollars. Lastly, the decision about what gets a high RVU versus a lower RVU is this RVS update committee. So they provide recommendations to CMS about the relative value of work. And we'll go on to the next slide. Oh goodness, I feel like I'm good. For me, I must have cut a lot of it out there, which is probably a good thing. So again, with the RVUs, and we will get into this a little bit later, some of the in more detail in the proposal is the fact that primary care, definitely an argument can be made that primary care RVUs are much, much lower than some specialty care procedure-oriented RVUs. So we're going to talk, when we talk about specialty care, of course, there's not just the provider fee. There frequently is a facility fee. There is also, say, the cost of a drug, and then there's other things too, for example, implants and things like that. All of that go into what makes up specialty care payment. Next slide. This is going to be an important distinction, which probably most people are aware of, but that procedures can happen, of course, in a hospital outpatient setting. They can happen at an ambulatory surgical center setting. Of course, these are planned procedures for the most part. And each type of procedure has an APC, so it has a designation, but the reimbursement for a hospital outpatient is significantly higher than the similar procedure performed in an ambulatory surgical center. Now, one can understand why this might be, potentially that hospitals have much higher overhead, but as most people are aware of, sometimes to enable things like to keep an emergency room open, which requires staffing and a lot of expense, hospitals kind of make more money on these outpatient procedures. Again, not a surprise to anyone, but it does have something to do with how everyone ends up paying for healthcare. Next slide. This one, so this is not a specific thing to specialty care, but just to keep in mind, I think everyone here is aware of when we talk about reference-based pricing, for the most part, we're talking about relative to Medicare. So if Medicare says this procedure, you get $500 for it, and so if it was a Medicaid would only pay $400, and then potentially a commercial payer would end up paying twice that. So maybe they'd pay $1,000. And so that's when we're talking about reference-based pricing. What we're doing is shrinking that into being able to, we're talking about things in units of Medicare fee schedule. Usually it's a percentage. So people are also probably aware that in Oregon, there's legislation that prohibited hospitals from charging the state employee plan more than 200% of what Medicare pays for, which has saved money for PEB and OEB, and that those charges aren't more in terms of what happens to the system overall, though, of course, that cost gets shifted onto other payers. So next slide. All right. I have a couple of models, and I am definitely not going to go into detail about these, except when we hit on the behavioral health collaborative care model. But I will just say these are all examples. They are CMS models, and I'll talk about sort of some of the pros and cons briefly. We're doing pretty good here. Okay, next slide. All right. So again, easiest one to think about is a joint replacement. And I just put the bottom line on these CMS models. You can see this one ran from April of 2016 to December of 2024. It ended up losing money to Medicare to the term of $3.2 million per year for paying for these bundled payments. I think when the years when CMS, quote unquote, made money from this, in other words, they ended up paying out less than they had thought. It's a little bit concerning if you read the fine print there. It says that the reductions in episode spending were driven by reductions in payments to inpatient rehab facilities, and that safety net hospitals served a greater portion of higher needs patients, but they got less repayment from CMS than non-safety net hospitals. So not only did this model lose money, it probably was detrimental to some of those safety net hospitals even more. So again, not all value-based care models are created equally. This one has not been, this particular model of episodic care was not successful in terms of money. For the most part, all the time, the quality levels remain the same. Next. Same thing. This one actually tended to be a little bit more successful. And I don't know if any of you all have participated in this type. They call it anchor-based model. So when someone has an acute event, such as an MI, that's a sort of an anchor event. And then again, there would be this bundled payment for everything. So from the time that the person was diagnosed with that event until the end of their care and sort of their either post-op or post-hospitalization care. Again, the quality, it said there was no significant change in readmissions or mortality. A little bit of an increase in readmissions for some and a slight decline in mortality for some others. So again, it all kind of came out the same. Again, when we talk about aggregate savings to CMS, that we're thinking of the aggregate savings to the payer. And so overall, it seemed to be a slightly more efficient way of paying for care where the performance and the quality was approximately the same. Next. Oncology care model. This one, I will just say, was not successful in terms of a financial standpoint. If you look, CMS lost $126 million a year from 2016 to 2022. At first, one might think, yeah, but there was a significant decrease in emergency department visits that led to these inpatient stays. However, practices that didn't participate in it also had similar results. So it is unclear why this was not particularly successful. And I will leave it at that. You guys can look into it more about the pros and cons of this one. And then next. I am definitely not an expert on the collaborative care model. I'm pulling this one out. I do, I suspect that there are many people who are here on this call who are more expert in this than, or have experience with this. This has been a highly successful model. I think it is somewhat similar to a primary care patient-centered home model in which, and it's interesting because it actually is a fee-for-service model, but the specific codes are created by CMS for this particular model, and those codes include so in general, the model is that there will be, for a person with behavioral health issues, not only is there a primary care provider, there is also a higher level, for example, a psychiatrist who is available for consultation. They don't usually see that person in person. And then there's also other sort of wraparound services from within the clinic for this patient. So these ones have, this was not a CMS study. This came out of the University of Washington, the Ames Center, and again, has been hugely successful. What some people have proposed is that this would be a great model for some other, especially in places like in Oregon, where we have a lot of rural communities that don't necessarily have specialists in person, but where you can have it be fee for service, but again, included in that fee is additional money that can be paid out to a specialist who, when you don't have the luxury, and I think Helen, maybe you can chime in for this, about working in a system that is integrated like Kaiser, where Helen, you have access to specialists on a more regular basis, people who don't always have that luxury. This is the availability to get that dedicated time, and then the specialist is adequately compensated for their time as well. And I don't know if anyone has any, maybe at the end of this, if people have experience with this, we can talk about this, because this has definitely been proven, I think, more even important than the cost effectiveness. It's incredibly successful and very beneficial clinically to the people who are involved in this type of system. Yeah, Helen, please.
Well, I was just going to say, I mean, it serves a lot of roles. It's a way of ensuring access to specialty care for the patients, but it's also a workforce issue for primary care. A lot of the difficulty of practicing in rural environments is lack of access or timely access to specialists. And so part of the reason, my understanding that this has been so successful in Washington is it's a win-win-win-win, right? Like, so the patients get the best care. The primary care docs are really supported. The specialty care docs get paid to be a consultant, so they don't have to see the patient to get paid, which they, on a fee-for-service model, they would. So they can get some portion of their salary compensated through this model without having to directly do face-to-face care. And so everybody wins in this model. And so, yeah, this is one of the more promising versions of value-based care in specialty care that I think is really worth adopting. And this obviously is happening in psychiatry in Washington, but you can imagine it could be applied to many other specialties that have a hard time with access in rural areas.
Yeah, thank you. And in the chat, it looks like, Jamie, that you have experience with it, but also a type involving gastroenterology, which is fascinating, child psychiatry. And then Gabe, it looks like your program is sunsetting. So I wonder, you might be able to comment about that more a little bit later when we get into the discussion. I'm going to keep kind of rolling through here, though. So we'll go on to our next slide. It'd be interesting to hear why that's sunsetting. ACO models, some ACOs have been very So again, when I say this aggregate loss to CMS, you got to think about it from the payer side. So sometimes when CMS says they're losing money, it's actually the providers are doing better. ACO models, financial incentives. So it's still somewhat of a fee for service because people are still billed fee for service, but there's more support available for patient engagement. I think that interesting, although it was not, again, financially successful for CMS, at least the losses were less at 5.7 million per year. No substantial change in hospitalizations or readmissions. However, and I think this is important, there was larger spending reductions for dual eligible members. Next slide. I'm going to just skip this one because these are things happening in the future and I don't have time to talk about it now. All right, pay for performance. I am certain all of you have been involved in some of this. So when I talk about this, these can be homegrown, this can be anything. So financial incentives and certainly quality incentive metrics, which people who see members who are of the Oregon Health Plan are used to this. And it can be incentives or penalties, carrots or sticks, to encourage hospitals, physicians, and other providers to meet performance standards. Lots of times this is usually the one that makes people go the most nuts because they have a high administrative burden, particularly and often on the people who are seeing the patients themselves. So between MAs and providers and things like that, there is a lot of administrative burden. I would say that there hasn't been fantastic success with these programs in terms of getting to really improved outcomes. So there've been improved process outcomes in ambulatory care. And this data is from an older study. So I think this is like before 2020, so maybe 2017. So I perhaps shouldn't have bolded the any setting, but that was from that particular study, the Affairs on Evidence for Pay for Performance. Next slide. So sum all of that up. Specialty care, it is a large percentage of total health care. Most prevalent system is fee for service. Fee for service compensation is based on RVUs, which some / probably many on this call would argue are disproportionately skewed, myself being one of them, towards higher compensation for procedure related care. And there are some specialty value-based care models that have demonstrated financial savings without a loss of quality. So it doesn't have to be all or nothing. So I think that's one thing to remember. And then if we go on to the next slide. I would love to get some feedback for this. If you could start from scratch and develop a specialty payment system, things that are goals of a specialty payment system, transparency, and then compensating for time, efficiency, productivity, outcomes, levels of expertise and materials and overhead. I mean, there is certainly the need for that. There are some costs that are inherent in a procedure. A colonoscopy has certain costs involved with that, even if it does take the same amount of time as seeing someone for an E&M visit. There should definitely be accountability in a specialty payment system and simplicity, which it seems to be sorely lacking. And I know this is kind of throwing this at you all. I don't know if other folks had things they would like to add to this list of a specialty payment system. Jamie, please.
Thanks so much, Mimi. This is helpful. A couple things I would say, maybe from one of the support staff. I did see at the beginning, maybe middle of last year, an article on towards a sensible specialty payment model in a universal healthcare. I can't remember the setting of it, but basically it just said like just add up what the specialty makes on a fee-for-service model. Figure that, divide that by the amount of services they're providing, and then do a salary payment model for that specialist. So each specialist's salary would say essentially the same based on the amount of work they were doing before the initiation. I was looking through my documents, I couldn't find it. So I'll keep looking, but I'm going to throw that little carrot out there for somebody to search for, you know, just as a slightly different model of, instead of doing a fee for service, should we look at the idea of salaried specialty? Similarly, you know, they often tout that the higher malpractice costs are the reason that they have to be paid 10 times more than primary care is paid. And not sure their malpractice is actually 10 times what family and primary care providers pay. So I'm not sure I buy that, but we might have an opportunity to make a recommendation to the board to look at malpractice payment models and payment reform, similar to how the military and FQHCs have a different type of malpractice coverage, because, you know, if I'm an active duty military member, I don't get to pick to go to an outside specialist. I have to go inside the military network. And because my choices are limited, there are fewer restrictions for providers in that setting. Because essentially providers are told you have to take care of this patient with what you've got where you are. And so there's a little bit of protection for providers. So maybe we could consider recommending someone looking into a malpractice reform as part of a strategy to reduce costs overall. Thanks, that's it.
Thank you. Helen.
Yeah, just a quick comment on what Jamie was saying, that yes, I think malpractice is with the operations committee as well, and the idea is, you know, there's two parts of malpractice. Well, we're looking at that in operations, to the extent that malpractice insurance is meant to cover the future medical expenses of someone who's injured as part of their care, that part would not necessarily need to be there anymore. So yeah, I think that is part of how we're considering how the universal health plan would interact with other types of insurance. But I was going to comment on this slide on the accountability one. I'm not sure what you mean by accountability in this regard, but I think something there should be a level of accountability of specialty care to their primary care colleagues. Like there is, even if you're not part of a single network or a single hospital system or a single plan, and that level of communication, coordination, and accountability with your primary care partners, because you're all sharing the same patient. So I'm not sure, you know, I would just kind of expound on that bullet point, being accountable and coordinating with primary care.
Yeah, thank you. And thank you, Eve, has a good component in there. And definitely specialists. There are plenty of specialists who are paid on salary for sure, but lots of times their fees are generated by fee for service. So I'll just toss that out there. So let's go on to the next slide. And again, I don't know if people had the opportunity to kind of look through the proposal. Apologies, because there was a lot in there, but I've kind of broken it down into things, and I definitely have some I hope that people will talk about, and I've broken it down into bullet points too when it comes to deciding things you would or would not like to recommend, or perhaps even amend as a recommendation to the board. So if we go through this, so the first one is perhaps not trying to this would be recommending not 100% trying to reinvent the wheel, but this may be, as when we get to it, a yes and also for, to Jamie's point, maybe consider a different type of salary base. But so continue fee for service and value-based payment methodologies for specialty care. If there are value-based payment models that have demonstrated financial savings while maintaining quality, prioritize those, such as the collaborative care and BPCI advanced models. Again, not too surprising and not really groundbreaking. This one I have incentivize / mandate a shift of procedures to lower cost venues when medically appropriate. This does kind of get into our question of, if we're able to do global budgets for hospitals, this would be fantastic, because hospitals would have enough to keep their doors open and wouldn't have to shift the cost of keeping an emergency room open onto pushing procedures to happen at the hospital, because they are compensated so much more. Yes, and we'll get to the line by line for questions and comments. Thanks, Eve. So thinking about that, is that something that should be incentivized? Or if you're the universal health plan, can you mandate that? So things to recommend. Next slide. Consider using reference-based pricing to provide sufficient compensation for underpriced services. So let's say something is, valued at whatever number of RVUs. Well, you could say, all right, well, we're going to actually pay primary care at 200% of CMS, whereas we're going to pay this other type of specialty care at 120% of CMS. So just because there is reference-based pricing, it doesn't mean like the entire state is going to be at 135% of Medicare. You can use that if you don't have, to perhaps change the way that the RBU system is skewed. This one, we definitely have a comment about this, about including provider payments in hospital global budgets, as it has been recommended, and we'll talk about that when we go through the vote. Get rid of low value pay for performance models, of which there are many and tend to be a massive headache for primary care providers and others. And lastly, prioritize uniformity, simplicity within specialty care to within the contracts, especially maximize administrative efficiency. So if we skip ahead to 2 slides, so we'll just skip the next one that says questions, and then I put them all on one slide. So if you're able to move these forward. This one, and then one more. Perfect. Sorry, because this is tiny. So this is what I'm hoping that we can do when we have this discussion is say, yes, this component I think is what we would like to go forward to the board. So that's why I have yes, no, and then yes with an asterisk, which could be where we get to the yes and portion of this. So just kind of starting off at the top about fee-for-service and value-based payment methodologies. If people feel that this is, go ahead, Helen, please.
Yeah, I just wonder if we should take a little break. Let's maybe give people a chance to read through these, think about it, gather some questions before we start going through these, and we could come back at like 2:55 and then ask some questions and kind of go through a vote on that. Would that work?
This is a great idea. Thank you. I'm sure everyone, especially myself included, would love that. Thank you.
So we'll just take 10 minutes. Please come back at 10:54, 10:55, and
2:55, not 10:55.
Sorry,
2:55.
Sorry, 2:55, and we'll get restarted again. Thanks. Okay, welcome back, everyone. Let's start and see if anyone has any questions or comments about the specialty care proposal so far.
Excellent. We'll start with Jamie and then Peter.
I had a question about the idea of centers of excellence in many actuarial groups. An insurance will have a way to select where a particular procedure is incentivized to be done because of better outcomes such as lower complication rates or lower rehospitalization rates, improved patient outcomes, and then patients are incentivized to participate in those locations. It seems like that might be something, I didn't hear anything about that in your presentation, but that might be in the line item of excluding low value pay for performance models. That might actually be a high value pay for performance or incentive type of model. If within the state, for example, there are 3 centers of excellence for bariatric surgery, and it is more cost effective to help patients go there to get great care than to stay home and get okay care that then might have higher complication rates.
That is a great point. That there is, which I there is a little bit of potentially a little bit of conflict with some of the tenets of what has been adopted to date with the universal health plan with the board, which is that people have the opportunity to see any provider that they would like. I'm not saying that that's insurmountable, and I think that is a great thought, and there may very well be a way to do something like that. So I'll yes, I think adding that centers of excellence, we'll have to think about that, but thanks, Jamie. I think that is a great addition. And then centers of excellence, Peter.
Hi. There's just so many pages of data to read for this, so maybe I don't know if this is.
I know
it's okay. I don't know if this is answered okay. My control F didn't find it. In number 3, who determines what is medically appropriate? And then similarly in the one under it, number 4, who determines like what the correct reference price is? Like what is the committee or the guideline or whatever for those 2 things?
Yeah, I have a short answer for the first one. So I will say a few things. There are some standard rules about that CMS has about when things have to happen at a hospital versus when they don't. So that's one type of utilization or criteria that can be used, Peter. And then another one could be this is when health plans have medical directors who make those clinical decisions, or RNs who make the clinical decision. So that's a potential for that too. Normally though, there's a standard list of criteria about people who have certain types of high risk factors where it needs to happen at a let's say at a hospital outpatient. However, if for whatever reason someone would also then perhaps be able, maybe they didn't have that meet that specific criteria, but their provider really felt like one place or another was more important, they would probably, then you could consider a way that they could request that and have that evaluated by say, for example, a medical director. So that's the first part. Who decides the reference-based pricing? That's a really great question. That's sort of a bigger question about that would be within this Universal Health Plan Governance Board. I don't know, Helen, if you want to take that on about within that organization, or not a board necessarily, but the organization of that Universal Health Plan, where is the pricing sorted out? And it probably would have to do with that, like the board of that Universal Health Plan. But Helen, I don't know if you have a better way to say that.
Yeah, I'm imagining, that if there was a public corporation running this plan, because that's what we've outlined, that they would set up a committee or a set of actuaries to figure out, how much the Universal Health Plan pays for everything, and they would use reference-based pricing. So taking what Medicare pays and then paying a percentage of that. We've already actually worked out the numbers for some of that because universal fee schedules are part of a cost containment strategy that we're exploring. So, but there would be some sort of committee, I would imagine, that would set prices and then, of course, reevaluate those prices and change them as needed and adjust them as needed. So that would happen at the level of the public corporation, a committee appointed by the governance board of that public corporation. We don't have to decide that now, but yeah, just that idea that that I think what we would put together is sort of like the sort of the gist of how it would work. And then those kinds of details would need to be sorted out if this were to actually become a thing.
Yeah,
All
thank
right.
you.
I'm going to go with Eve next, then Tony, then Betsy.
Thank you, and I'm in transit, so again, apologies for being off camera. A couple of points here. One is on the potential mandate to a lower level of care. I think that when I managed orthopedics, there were two reasons that we identified that surgery centers turned away our patients when we wanted them to be there. One was that the patients were covered by Medicaid and they couldn't pay the bills. And that won't be an issue, I assume, in this new model. The other was that the implants that the physician wanted to use were too expensive and they didn't pencil for the surgery center. We're really going to have to look at implants if we want to try to mandate lower cost of care setting for some of these procedures, because the hospital payments tend to have enough cushion that they can pay for some of those higher cost implants, even when medically it would be appropriate to do it in a lower cost setting. So anyway, that's just an asterisk on that one. And then the other point, which I know, Mimi, you and I have discussed via email, is just that the only time I support payments for physicians being part of a global hospital budget is when the physician is employed by the hospital. If we create a system where global payments are going to the hospital and the hospital has all the control in the negotiating process because of their size, and we're requiring specialty physicians to negotiate with the hospital for their fair share, I think that's going to go real bad. And we would have the potential of losing specialists in this state over that type of a model. So I support that independent specialists can still bill for their own services and be reimbursed independent of a hospital.
Thank you. That's a great way to make that distinction to being employed by a hospital or not. So I think that is that would be a way to put that in that for include employed provider payments in hospital global budgets is one way that it could be amended. So thank you.
Thank you, Eve. You answered the question I threw in the chat, not knowing you were in transit, which was, it sounds like we might be putting hospitals in a double bind if we tell them that they have to pay the salaries and they also have to move procedures out.
That's right. Pay more, do less. Well, presumably they would be doing less, so they wouldn't have to pay so much. But yes, I think that's an excellent distinction and I think a good amendment. I think, please help.
Well, can I just clarify, Mimi? When we talked about global budgets including provider payments and global budgets for hospitals before, I think we were just referencing if the clinicians are employed by
yes, but I think just like specifying that I think is really important because it could definitely be misconstrued. Yes, so thank you.
Yeah, so that was so and then I'm just wondering, I know this is picky, but like if we can refer to clinicians, providers could be, as we learned before, like, you know, a hospital or an insurance company, or provider refers to a whole bunch of players.
Yes, absolutely. Thank you. Yes.
So include so I would say when clinicians are employed by the hospital, their salaries would be included in hospital global budgets. That's the idea of this point.
No, thank you. I appreciate that. And then Tony.
Yeah, thanks. I just to reference to the thought of having this entity of the governance board to weigh in on these, because, you know, if this thing gets off the ground, it's going to be initial, you know, thought process, but it's going to have to have ongoing evaluation and with reference-based pricing, and, you know, do we try new models as far as fee for service or value-based models? Kind of that first line, we're not really making a decision, fee for service and value-based, right? So, I mean, inevitably it's going to have to come down to looking at best practices and seeing what's work in the system, right? You know, it is interesting, just our observation of pay for performance. We talked a little bit of this in primary care and the frustration of pay for performance and how it doesn't work in specialty care and in the setting of primary care. That's also challenging. That was a little bit of back to the conversation of the definitions of value-based care. But I just think that having that entity, similar to our conversation, say what is evidence-based, right? What is low-value care? There's going to be that entity that's going to help to derive those decisions.
Yeah, absolutely. And I realize, yes, continued fee for service and value-based based payments isn't really a groundbreaking sort of, or anything that really changes it very much, but I just had to start somewhere. So thanks, Betsy.
Thanks. I have one question, and I apologize if it's answered someplace that I just haven't seen. When we talk about pricing, do we anticipate making pricing transparent to the patient as well? Because one of the things in our current system is that, the pursuing the most efficient care may not be within the control of the patient, right? That if the MRI can be obtained cheaper in a different place, but that's not in network for their insurance company. So that you go where your insurance company sends you. That's one piece. And the other piece is, I think when we think about the way that we're going to engage the public in accepting this, we need to be mindful that, when I worked at Q Corp and we were constantly trying to work with patients and having them understand best value for cost, patients often view higher cost as better quality automatically. I want to go to the fancy place. I want to go to the center of excellence. And that might be a complicating factor as we try to predict cost and also, incentivize patients to pursue the paths that are best overall.
Yeah, so when just sort of specifically thinking about that, I mean, I think that's why I have the incentivize / or mandate procedures to lower cost venues. And I live in rural Oregon, so of course there's lots of reasons why it is people don't drive into Portland. Sometimes you can't get into Portland to get an MRI. So there have to be a lot of caveats to that. And then you get into the question, I mean, presumably, that there would be, people do have options. They can go wherever they want and potentially pay out of pocket for it. But I'm trying to think of a way to maybe just leave it as incentivize, keep out the mandate part. And again, this is very broad when we're talking about the kind of what we're recommending to the board. But if people have other ways to wordsmith it, I'd love to hear about it. But I definitely get your point, Betsy. I appreciate that.
Mm-hmm. Yeah, I think keeping it to incentivize would meet that. But I think Betsy's point too was about transparency, and that in this case it would only apply if we did some version of cost sharing with the more limited benefits. But if that prices will be transparent, if there's any element of cost sharing with services or procedures, that the prices will be transparent. Is that what you were getting at, Betsy?
I think I would argue it's potentially worthwhile for people to know the value of the care that they're getting, whether or not they have they specifically individually have a financial stake in it. In terms of the sort of social acceptance of this, hey, Mrs. Smith, you had a knee replacement, and that the value of that knee replacement for all the taxes you've paid for this plan is this. So people can yes, exactly. So they have a stake as a taxpayer, and understanding, I would love for us to be in a system, and this may be out of place in this conversation, so feel free to just swat it down. I would love for this work to lead to a system where people really understand how healthcare works, what it costs, and what they're getting, whether or not they're paying for it through their taxes or through a copayment.
It's a really interesting point.
And there actually are a lot of transparency laws that they're laws, but they aren't necessarily in effect yet, right? And we know
they don't work, right? I mean, if hospitals are supposed to tell you what a procedure costs, but they almost can't do it because the particularities of your individual case are so complicated. And so I do wonder whether, as we're talking about negotiating this all without the patient, we should be thinking about.
Absolutely. Your tax dollars it works. Thanks, Gabe.
Exactly, Gabe. I mean, it's any other infrastructure, right?
It's such an interesting point. Yeah. So to build transparency about the costs of services, I think that's really great. To include that. Can I make a small edit?
Please.
Can
You bet.
The first one about the continue, I would say something along the lines of continuing to use a combination of fee for service and value-based payment methodologies in specialty care with ongoing evaluation for, you know what I mean? Like to determine sort of what's best or what's going to be most effective in each context, right? So, so I would just change that to continue to use a combination of, because all of the universal health plan systems that we've looked at in other countries, all of them use a combination of fee for service and value-based payments. There's none that's exclusively one or the other. And I think that, you know, to your point from your presentation earlier, Mimi, there's like different specialties and different situations call for different types of payments. But to some extent, we will use a combination of both and evaluate them for effectiveness, appropriateness, something along those lines.
Thank you. Yes, I think that is a great idea. And luckily we have the transcript of this. So we'll be able to really get the words in there. But Tony.
Yeah, no, I appreciate that, Helen. And I think really kind of what it comes down to is we're maintaining existing structures of payment in specialty care. I think that's kind of a little bit of what that's kind of getting at. There's a few nuances below, but we're not really rocking the boat on this one. We're kind of following that there are existing structures in both those sectors.
Yes, I completely agree with that. And then just like I said, though, trying to, I mean, you know, there's whatever 20, 30 years of data about things that have been successful and things that are not successful. And to actually use that data to the benefit of the people that we're trying to cover. So if oh, Helen, yes.
Well, I want you go ahead and finish your thought if you want to.
No, go ahead. And then Jamie has her hand up too.
To what extent do you think that if we were to implement this, sort of you alluded to this in the beginning, that we probably pay specialty providers too much, and especially if we're going to increase payments to primary care, to what extent, you know, will that happen? And what kind of safeguards do we need around specialty care to prevent our specialists from leaving if their pay does indeed go down? So Jan.8, you know, early on in our work said that in Taiwan, they sort of protect certain streams of funding. I'm inventing an example of like trauma care. So you want your trauma surgeons to stay in your state and not leave, because if you don't have any trauma surgeons, that's kind of a problem. So they would protect a line of funding for that specialty and guarantee them a certain amount of payments regardless of their volume so that they wouldn't leave, right? And I'm just wondering, like, there's certain specialties that we wouldn't want to drop below a certain number because, right, if we pay them less, you know, we don't want that attrition to be so severe that it'll affect patient care.
Do you think that's something that should be put into this model as sort of like an evaluation of, I don't know, I want to call it like critical services. I'm not coming up with good verbiage or something like that.
Yeah. Consider ways to guard against specialty attrition related to changes in payments, changes in provider clinician reimbursement. So consider strategies to, you know, mitigate clinician attrition, you know, specialty clinician attrition from the state. So yeah, just something, but just to consider that, you know. I don't think we need to come up with a strategy now, but just to put something in this proposal that acknowledges that that might be a thing and we might need to guard against that.
Thank you. And I think Jamie, then Eve.
Thanks. I agree with what was just said. I think, you know, critical access specialties need to be identified and particularly cared for. I just want to call out there's a pipeline issue that we, on the one hand, I appreciate let's not rock the boat too much. On the other hand, this is our one chance to rock the boat on things that haven't been working for centuries. And what hasn't been working for centuries is incentivizing procedural specialties and disincentivizing primary care and cognitive specialties. And we have a chance to recommend that that be gradually rectified in our state. And so I just want to throw this consideration idea out, that the gap in payment between a procedural specialist and a non-procedural specialist, I am a non-procedural specialist. I have specialty board certification as a primary care physician. I can perform procedures, but the majority of my income does not come from procedures. Alternatively, an interventional cardiologist has a different sort of practice model than a hospital and office-based cardiologist who is not doing a lot of procedures. So maybe there needs to be some nod to there is traditional overfunding of high-tech, high procedural specialties. And we have an opportunity to request that those have lower reimbursement than they have traditionally had in order to support the infrastructure of primary care, behavioral care, and cognitive specialties that can prevent people from needing to have high-tech, high-cost procedures like a cabbage. If we had more primary care to deliver statins to people, or to get their diabetes under control, or to help them quit smoking when they are having vascular disease, can we use this moment to recommend a shift, even albeit gradual, away from procedural and technological? We're just so in love with that. But it's not actually what saves lives over the long run. What saves lives and reduce cost, and I'm going to go out here on a limb, I'm going to say it's family doctors operating in a primary care medical home. There are no other specialties that have the trifecta of reducing cost, improving quality, extending life expectancy, other than basic, excellent primary care trained physicians. And the infrastructure that we need to put around them with APPs who are excellently trained as well is fantastic. But if we miss this opportunity, we're only going to be creating another high cost system that's difficult to fund.
Just quickly in response to that, I 100% agree with you, Jamie. And I think it's important to call out the two separate things, that what we're talking about in this proposal is how clinicians are paid, not how much they're paid, right? And so the strategy to get payments to them through various methodologies, but you're right, built into this, we should include some sort of plan to shift some money away from the high cost of those procedures and pay, when we set like universal fee schedule for how much we're willing to pay for those procedures, that's our opportunity to say, we've been way overpaying for cabbages. Let's pay this for cabbages, and or like you said, phase it in, start 10% reduction by year until we get to what we feel like is a fair price for it, and then shift it. So that shift of the money, I think, will happen with a fee structure. And that's one of the best things about a universal health plan is there's a single fee structure, right? Like you don't have, 200 insurance companies paying different amounts for the same procedure. You have one fee schedule. And so you can decide how much money you're willing to put into which things. And then your point is a really good one, that we could shift that.
Eve.
Thanks. I would just recommend that we be super cautious about what we really can control, doing this as the state of Oregon rather than the country of the United States. It would be very, very easy for critical needs doctors, even if we feel that they are overpaid. When you need a specialist, you need a specialist. And if we don't have access to them because we've decided that a certain specialist group is overpaid and they can be paid kind of the standard across the country, one state north or south, we will find that specialists will leave. They tend to be a group that can be mobile, because a lot of times they are mobile through medical school, residency, and potentially fellowship. So it's kind of like the argument that a hospital CEO doesn't need to be paid $1 million. True, a hospital CEO doesn't need to be paid $1 million, but if hospital CEOs all over the country are paid $1 million and a hospital here decides to pay them $300,000, they can't recruit an experienced CEO. And I think we'll find ourselves in the same situation, and we'll find ourselves with Oregonians not having access to critical care when they need it. So I would just caution how much of the system we try to overthrow as a single state.
Thank you. I think I know. I mean, it's absolutely true, and it's a tight. Let's face it, it's a tightrope. Who says we need CEOs? Thank you, Peter. It is a tightrope, and if in case people are wondering about my the language in some of this, which is fairly gentle, and it's that way for a reason. So it is the potential to work towards those things, but certainly in the writing and in presenting this to legislatures or other things, we may be able to provide more sort of meat onto what the actual recommendations are. So I think what I'm hearing, you guys tell me, I'm just the worst note taker ever, but with point number 1, continue fee for service and value-based payment methodologies with this ongoing evaluation for efficiency and efficacy. I don't think anyone's going to disagree with prioritizing models that work. We're going to strike out the word mandate and incentivize shift of procedures. I'm just going to put higher value venues, just because lower cost always makes people think that it's going to the, the Dollar General ASC. Is there any heartburn about utilizing reference-based pricing to provide sufficient compensation? Okay, we're going to keep that one. It is include clinician payments in hospital global budgets, but I will put in there in a more correct fashion, sorry, those who are for those clinicians who are employed by the hospital include their salary within the global budget, something like that. So I think it's a great call out. Excluding low value pay for performance models, yes. Uniformity, simplicity, and it says to maximize administrative efficiency and transparency, but I really love the point about who we're being transparent to. And I think when we kind of write the report, we can really emphasize that about building that into all of the work that is done here. So if people feel okay with that and trust me to make those changes, I might ask for or actually, Helen, I'll let you lead this if you want to get a motion and a roll call.
Does anyone have sort of further sort of issues with any of these kind of, I feel like we've sort of captured the feel of what we're trying to do here with specialty care. Does anyone feel like we've missed something?
I won't send that to you, Gabe. You don't want all those EOBs cluttering up your mailbox? Fine.
Okay. Then yes. So then I think we should take a vote of the committee members about whether or not with the edits that Mimi just kind of went over, that this is a proposal that we should send to the board. Again, so the vote would be yes, we are ready to send a specialty care payment proposal to the board as presented here with the edits. Is there a motion for that?
I would move to send it through as presented with the amendment.
Great. Is there a second?
This is Mike. I'll second.
Okay, great. Any further discussion? I don't see any hands. Okay, let's do a roll call vote.
Helen Belanca,
Yes.
Jan.8 is absent. Peter Addy,
Yes.
Gabe Andine,
Yeah.
Betsy Boyd Flynn,
Yes.
Mike Durbin,
Yes.
Rob Fizette is absent. Tony German,
Yes.
Eve Gray,
Yes.
Rosemary Hemmings is absent. Julianne Horner,
Yes.
Max Kaiser,
Yes.
Jim McGee is absent. Peter Merritt,
Yes.
Angela Mikhalik,
Yes.
Jamie Osborne.
Yes.
Thank you. That's everyone.
Great, thank you, everyone. Okay, we're going to do a slight change in the agenda. It's almost 3:30, and we wanted to get to the behavioral health proposal. So we're going to shift to that right now, and then I don't know that we'll have time at the end, but if we do, we can circle back on some of the other issues. But Lee has put together a fabulous pharmaceutical presentation that we will hopefully get to very soon. But let's take a look at this one for now. So this committee has already considered how behavioral health will be integrated into a universal health plan. We had a pretty extensive discussion about all of the services that we want to make sure are included in the benefit design. And as I mentioned earlier with the Milliman presentation, this is the plus part of PEB Plus of the benefits we would offer to all Oregonians, is making sure that we have really robust behavioral health care services. I know that all of you know this too, that behavioral health in this state is very uncoordinated, discombobulated in the way that it is paid for. The funding comes from a number of different streams. The billing is different than traditional medical billing. And so it's a very sort of pieced together system. And what we wanted to do is use the Universal Health Plan as an opportunity to organize it better and to think a little bit about how we could pay for behavioral health and administer behavioral health in the state in a more coordinated, responsive way. So I want to preface this discussion. Lee's going to show us some slides here about what we're thinking that we'd like to get your approval on. And I want to preface it by saying that no benefits have been removed. All of the benefits that we talked about before are included in here. This is just about how it's sort of organized and administered. So I'll hand it over to you, Lee, to get us started.
All right, thank you. And as just mentioned, indeed, this group has already considered benefits. We are not touching that part of the proposal. We're really looking at financing and integration here. So specifically, if you hopefully had time to read through the proposal, you saw that we're looking for approval on a preliminary policy direction for funding alignment for behavioral health, payment architecture, and various integration models to ensure that behavioral health and primary care are closely linked. Next slide, please. So these are the guiding principles that we use. These are drawn from past discussions. The board and this committee have had things such as public corporation, holding all the risk, wanting to use evidence-based model standards that we know are effective. And really, one of the core goals, of course, of universal health is streamlining and simplifying administration and financing where possible. So taking these guiding principles into account is really what led to the development of these particular items. Next slide. So when we look at behavioral health funding, it is, even in terms of healthcare standards, a very fragmented financing. This is just public financing. So of course, we're not talking about how private health insurers fit into here, though of course they do. But really what we have on the public side, we have Medicaid, really an unknown amount. It's built into the capitation rates. Separately, OHA does have other streams of behavioral health funding that are interesting to note. Behavioral healthcare division that has its own programs and statewide initiatives, et cetera. County financial assistance agreements are a really big source of behavioral health funding. This goes to a lot of different things: treatment, county types of programs, intersections with public health, et cetera. And this is really, it's considered non-Medicaid safety net behavioral health funding. So this is for safety net purposes, but really payer agnostic. We also, of course, have some crisis funding in the form of the 988 Trust Fund. This is for mental health emergencies. And then there are federal block grants that are provided. These often funnel through the OHA and out to counties. Next slide. So keeping alignment in mind, we really group these into 3 different buckets, kind of a red, yellow, or sorry, green, yellow, red, if you will. Under green, we have recommended for immediate alignment with the Universal Health Plan. And predominantly under here, we are really talking about the County Financial Assistance Agreement treatment dollars. So those monies that counties currently receive that are specifically directed at treatment dollars. Notably, a lot of these come from syntax type things that are intended for behavioral health purposes. And so we can pretty specifically know which of those dollars the counties are currently getting that are in fact for treatment purposes. Additionally, within OHA, the Behavioral Health Division, spending that's explicitly non-Medicaid. And the reason for that, as we move into our second bucket, is because there's another category of funding streams that I think ultimately we are recommending this committee suggest for alignment, but also noting that this alignment may take longer because these are federally constrained dollars, they're subject to waiver processes, and so they may not be part of an immediate universal health plan. They may take a little longer just logistically to get on board, but the goal being for eventual alignment. And that would be Medicaid dollars, those remaining OHA Behavioral Health Division dollars that are used for federal matching funds would want to be careful before moving those over, that federal match is not going to be impacted. And same thing with those block grants. Really, the key one to note as functionally distinct is that 988 trust fund, given that that is really sitting at the intersection of behavioral health and public safety. The consensus was from staff that the recommendation should be to have this as distinct from a funding perspective, but to integrate with respect to requiring things such as warm handoffs and policies that are fully integrated with crisis. Due to time, I am going to wait till the end to respond to any questions. Next slide, please. When we look at different models for integrated care, there are a few, some of which have been already mentioned today. The Certified Community Behavioral Health Clinics, Psychiatric Collaborative Care Model, and another model known as Hub and Spoke that was really popularized in Vermont, but has also been adopted in California. And a lot of these, as you can see, have the top box, the top dark blue box for each of them are really the delivery aspects that are integrated. So explaining how that behavioral health system is aligned in a stronger way with the primary care system, or even just with itself, so that those referrals can be made, triage can be done in sort of a location appropriate manner where you're receiving the right level of care in the right setting. That bottom box really refers to how that payment is structured to encourage it. So you'll notice Hub and Spoke is a pure delivery integration model. There's no payment aspect, but we do see with the Certified Community Behavioral Health Clinics, as well as with the Psychiatric Collaborative Care Model, there is a nod to integrating that payment function as well, specifically to expanding payment to account for some of that additional time that's needed for care coordination, that's needed for expanding services in a way that truly allows behavioral health to be an integrated service rather than to function as a silo. Next slide. So that payment architecture, if we break down what we've seen from those community behavioral health clinics, as well as the psychiatric collaborative care model, we really see that we're talking about a behavioral health payment that has 2 core components. The first, which is familiar to everybody, we're reimbursing for clinical services. So this would be that PMPM that covers direct services that are provided, and there could possibly be some episodic payments as appropriate for higher intensity care, things where there needs to be regular ongoing check-ins and coordination regarding a particular patient. It's the second piece that we see in integrated models that have proven particularly successful, which is the capacity infrastructure payment. This is in addition to clinical services. So we're not necessarily talking about reimbursing more for a given service, but we are talking about reimbursing more for the work that has to be done to provide high quality integrated care. And this is really to fund capacity. It's to fund expansion of services. It's to fund everything that we want from our behavioral health clinics and that they want to be able to provide, but aren't able to due to funding constraints. So additional walk-in capacity, coverage and service enhancements, and availability to potentially more providers or to telehealth, et cetera. So making sure that we are funding not just the services provided, but the services that we expect them to be able to provide. Next slide. So I've broken this down into some of the design factors for success, and I've placed it here because this really bridges, I think, what we just talked about in terms of how you structure a payment and then how you go to that really integrated delivery model, which we're going to end with here. So that payment being inclusive of indirect non-work visit and capacity building, really essential to these models that have shown success in reducing behavioral health ED visits and lowering overall costs in that sense. Also incentivizing participation in primary care integrated models. This is often achieved through that capacity or infrastructure payment by holding that out as an option. There is additional funding for you if you are willing to participate in this, and that gives clinics both the financial impetus and the actual ability to be able to do so. And the number 3 in terms of design factors for success, and this is really in alignment with the previous recommendation around having that Medicaid level of behavioral health services, but aligning with those Medicaid standards in terms of medical necessity. They have very minimal prior authorization for behavioral health, and aligning as much as possible with what is required on that federal side as part of that administrative simplification. Next slide. So as we think about the care delivery aspect, of course, the board has settled on a model wherein there is the public corporation, and then there are various regional hubs that are going to be available to make specific decisions about more locally how their healthcare is going to function based on local culture and resources. So we are looking at this as a regional access model. I do want to reiterate, regions are not service areas. So just because a region chooses something does not mean that a person living in that area is held to it. This is simply an organizing way for us to think about how are we going to enforce similar standards, similar access to behavioral health across the state, which has a lot of variability with respect to being rural and urban and whatever its major transportation is. So under this model, regions would be able to select their integration model where appropriate, and they could even blend them. So they could have kind of a blended Model 1, Model 2 option. This would be flexible and would ensure that they are meeting the communities where they are and providing a level of kind of state support essentially to help fill in whatever resources are needed so that everybody can meet those same evidence-based standards regardless of where a person lives in the state. That region may have a slightly different model, but based on that model, that's essentially the extent to which they're going to rely on, say, under Model 2, more of that virtual network, more telehealth, or under Model 3, where they have more resources that are directly from the state, mobile extensions, for instance. Next slide. This is really that same information, but just kind of broken out to model what these look like, who would be the best fit. Model 1 being good for regions such as, say, Multnomah County that are highly resourced and would be able to have a central integrator. Model 2 being, again, that virtually integrated network for kind of mixed or fragmented types of regions, maybe those that have a few major kind of urban hubs, but a little more remote. And Model 3 probably more for kind of that Eastern Oregon where they don't have so many central urban areas and you're really looking to try to cover a large area and to make those resources work for you. Next slide. So similar to what we had before, this particular behavioral health proposal just has these 3 buckets that we talked through, and I will hand it back to you, Chair Blanca.
Great. Thank you so much, Lee. I really appreciate you going over all that. And I want to give a shout out to our Vice Chair, Judy Richardson, who did a tremendous amount of work developing these models as part of another role she has. So before we discuss this, does anyone have any questions?
Eve has her hand up.
I don't think I understand funding alignment, particularly as it relates to the CFAA, much of which funds court mandated services that are clinical in nature, but not reimbursable from the medical system today because they're mandated by the court. Are you suggesting that the healthcare system now manage those services that have traditionally been the realm of public safety, forensics, and the state separate funding systems?
Lee, do you want to take that, or?
Sure. I was not aware of that particular thing. I think given my research, I would suggest that anything that has that strong public safety component is probably to be distinct from the universal health plan. So I would suggest carving that out, but I will defer to members of this committee how they feel.
Yeah, my understanding would be that it would be separate, that it wouldn't be integrated into the universal health plan, that it would remain a separate source of funding. I think go ahead.
I would recommend deleting the CFAA then, because the reason for that funding largely is things that are, there may be a small part of it now, but the way that we're being required to prioritize services, it's all forensic mandated. It's the court investigations for civil commitment. It's monitoring people for the Psychiatric Security Review Board. It's helping get people competent to stand trial. Those are the types of services, largely vast majority, that are funded by the CFAA, and by state law, counties must run those services or define who provides those services. So I think we get into a real sticky wicket if we're trying to pull the CFAA into these conversations.
Okay, so quickly going back to that early slide, Lee, that shows the recommended funding alignment. It would eliminate that first bullet on immediate alignment, but keep it, and then so that CFAA would be eliminated from that alignment, and then the behavioral health tax revenue, and then the OHA behavioral health division that's non-Medicaid, and then it align eventually with Medicaid and OHA behavioral health division, Medicaid dollars, federal SAMHSA block grants, and then that 988 trust fund would be functionally distinct, as well as, and put CFAA under this red category as well. Is that right?
I would anticipate a huge number of politics on this slide. You know, a lot of the kind of syntaxes go to support public safety programs, not just and public health programs, which will be separate from kind of the individual service provision here. I think this is a slide that needs a whole lot more discussion across the state, because it could hold up. Some of these rejiggerings could create a level of opposition that would hold up kind of the greater good of what we're trying to do. So exactly where, I can't anticipate where all of the opposition will live. Definitely bullet points 1 and 2 will have significant opposition. OHA behavioral health division funding, explicitly non-Medicaid. I guess I would have to look at a list of exactly what that is to identify where opposition may live. But yeah, I just think we're going to get ourselves into a delay here with some of this.
So we could change this first. So if we go back to the proposal one where it had the 3 things. Where are we? Yeah. So instead of approve the 3 funding alignment buckets, we could adjust that to say, sort of prioritize alignment of as much behavioral health funding as possible, with plans to sort of integrate other sources of funding over time, you know, that kind of wording, just to make it to say like whatever is easy and obvious. I'm not sure what that would be. I don't know if Eve, you have a recommendation for that, or maybe we should, why don't we do this? I wonder if Eve, we can have you and Lee work offline to kind of put together a funding, like what could we pull in now? What could we pull in later? Like, and maybe just kind of that a little bit. Yeah, let's do that offline.
Yeah.
Come back.
And if we can rope Cheryl Ramirez into that, she would have so much wonderful perspective on where the opposition may lie.
Yeah. Yeah, that's a good idea. Can we make a note of that, Mimi and Isabel, like Cheryl, Eve, Lee? Kind of pull together.
Have to buy Cheryl a box of chocolates, but yes.
Yeah. Okay. Okay. Thank you, Eve. Yeah, that's the kind of stuff that unless you're in the system, it's just hard to know how feasible or not feasible that is.
I'll get you a box of chocolates too, Eve, if you want. I wouldn't be.
It's okay. We can give that to Cheryl, but her constituency is going to care deeply about this, so I think she'll want to be involved.
Okay. Any other questions about the other two, the architecture, the, you know, in terms of clinical and capacity payments, or the regional models? I don't see any hands. Are there any hands? Oh, Jamie.
Jamie just did, yeah.
I don't have a question. I just want to say how thoughtful that is. I'm really appreciative of the 3 models for different regions based on what their infrastructure capacity is. I think that's really thoughtful. I appreciate it.
Yeah, I think Judy did a great job on that. That's totally her work, and really with an eye toward how rural communities function in this space. And yeah, she did a really great job of that. Happy to give it some sunshine.
And Tony.
Yeah, I just want to say kudos. I mean, this is remarkable work. And I just think like this effort in doing universal health care affords this type of delivery of care that has been so difficult to accomplish in a state. And our troubles with behavioral health, I think this is, you know, just really forward thinking, and the collaboration of care models, integration of this is really exciting.
Great. Other comments, questions? I don't see any. Okay, so we have a choice here. Option 1 would be, we'll have a little funding alignment sort of discussion offline, and we could bring it back to our February meeting for a final approval by the committee. Or this committee can just say, we trust Eve and Cheryl to figure out how the funding alignment would happen. They will meet and do that on their own, and will incorporate into the proposal. And so we could approve this proposal with the architecture and the regional model framework, plus whatever they agree is the right wording around funding alignment. And so we could approve it today and just know that they'll be adding that in, and we won't see that before the board sees that. I'm good either way. I don't know if Lee or Mimi, you have a recommendation for which one we choose.
My only thought is that since the board meeting is just 1 week away, it might be reasonable to wait.
I forgot
present the whole thing. Yeah, I know, it just snuck up on us.
It sneaks up because we moved this meeting because it was going to be on the 1st. Right. No, yeah, that's a good point. Our board meeting's next week. Okay, never mind. So we will rethink the funding alignment piece, and then we will quickly revisit this proposal when it comes to the board, and bring it back for the February meeting, and then it would go to the board at the board's February meeting. Does that work?
Yeah, I think that makes more sense.
And then give everyone a chance to.
Yeah.
Awesome. Okay, cool. Can we circle back to the agenda? I think it's just the pharmaceuticals and the cost containment that we had to waylay. Is that right?
Yeah, it was just prescription drugs beyond the basics. Which it's, yeah, you don't want to rush through that. It's such a good presentation.
Yeah. Okay, great. Yeah. So any reflections, feedback? This committee is only going to meet 2 more times, February and March. And then we will be wrapping up this committee in order to do some reconciling with other work and do the transition work. So in the next 2 meetings, in addition to what we've talked about today, apologies, my dog's getting hungry for her dinner. In addition to what we talked about today, do any committee members have any requests for things that we need to revisit or talk about again, or make sure that we have time for in the last 2 meetings? Tony?
Yeah, thanks. I was curious about being a governance board. We'll have just 2 meetings and then we'll disband, or would this be something that would be standing should you guys have questions about in the future?
Well, this isn't a governance board, this is a committee. So yeah, our plan is to sunset all 4 of our committees and then launch our new transition committee with members of each of the committees involved. So we're pulling together a transition committee to kind of help with that work. But yeah, the committees will sunset, all 4 of them, not just this one, will sunset in March so that we can start to do that reconciling.
Except
work.
for CECC, actually, community engagement and communications is continuing. Sorry.
That's right. Yeah. So CECC decided that they're going to continue on, with their work. Yeah. But the 3, finance and revenue, this one, and operations will all sunset in March, and transition will launch, and then CECC will continue.
Great. No, thank you for that clarification. Just as I shared comments earlier, trying to be helpful and contributory, but it sounds like the game plan will be you guys will convene a transitions plan, which will be further developing, that conversation with regard to finance and eligibility and the discussion of, what's on the table, what's off the table, what are we taking in, what are we putting in, and it sounds like that will be in that context. So,
so to clear,
yeah,
that's not the work of the transition committee. The transition committee's job is to say, okay, here we have this plan. We have our current state of the health system, and here we have this plan that we want to get to. How do we outline all of the steps that need to happen between now and then in order to implement a universal health plan? That's what the transition committee is, transitioning from status quo to universal health plan. The reconciling work of pulling together all the recommendations from all the committees and coming up with that final version of the plan, that's the board and staff working with our consultants to make that happen. Yeah. But I'm sure we will tap individual members if we need clarification or we need to kind of run things by people. I'm sure that we'll tap some of our many experts on all of our committees if we need to do that work. But that happens at the board, not at the transition committee.
Okay. In the next 2 meetings, I think it'd be interesting to hear more of that conversation since we can't convene together with the finance and revenue, but just that back and forth. And I would be encouraging if finance and revenue has questions to this committee as far as what would be things to take off the table, as referenced today, that lean program. I think that lean approach needs to be distilled down further to kind of what that means and other ideas with that. And so I would just like to, personally supportive of that effort as best we can.
Yeah, every board meeting when the committee report outs happen, the committees say if they have questions for other committees. So we've done that from the beginning, where one committee poses questions to other committees. So yeah, we always have that option. Yep. And we can emphasize that. Anything else we want to see in the next 2 months? Sorry, is there a hand? Oh, Peter.
Yeah, hi, thanks. Just as a general comment, since we're kind of winding down here, and especially in today's meeting, we were talking a lot about the scarcity of options and the lean options and things like that. And I've really been motivated and inspired lately by learning about the healthcare system in Cuba. I got this great book right here from the library. And as you may know, so Cuba was largely funded by the Soviet Union until it was illegally dissolved in 1991. And then Cuba, their GDP dropped by 1/3. They lost 1/3 of their revenue overnight. They called it the special period. It's worse than any budget cuts we're ever going to see in Oregon. And everything, all of their budgets statewide had to go down significantly. But the Cuban people decided to increase relative spending on healthcare by 13%. They actually, everything, all the spending went down. Healthcare spending relative went up because everyone just understood how fundamentally important healthcare is and how spending money on healthcare will reduce spending on other things later. So focusing on healthcare, focusing on social determinants of health, this is precisely the time to be bold, to ask for more things. We have to do more with less, and so I know this committee doesn't have any say over the state budget, but like the things that we do have say and the ability to influence, now is precisely the time to ask for the most things and to really push as big of an agenda as possible. And it's going to have any savings, any help that we have here has all these downstream effects that will just be improvements for everyone. And so I just really hope that that us and the main board itself can convey that. Well, that's all. Thanks.
Yeah, thanks, Peter. Did I miss anybody?
Nope.
Okay. Okay. We have one person signed up for public comment, and in addition, we had some written comment to this committee. I encourage all the committee members to look at the public comment that's in your written materials as part of today's agenda. Jason Street commented on the financing model. Lou Sinninger wrote in about the financing model and also advocated against value-based care. Linda Krieger asked us to reconsider our primary care proposal. And then Bruce Thompson submitted an overview of health policy that was written by Stephen Kemble. So all of those are worth a read. And we have one person signed up for oral comment. I believe it's Lou Sinninger. Lou, are you ready?
Oh, there we go.
Great. Welcome.
I don't know if you can see me or not, but we'll try it. Okay. It's hard to, at times I think that the industry is changing faster than the governance board. One of the things I wanted to say towards the end, but I'll say it now, is I wonder how your payment plan that you come up with and everything will impact urgent care organizations. The family physician seems to be almost gone, and urgent care organizations have taken over. As far as the proposals of excluding medical care or Medicare and leaner benefits, I have to tell you that co-pays are a deterrent of care. And I can only, also 1/3 of our population is on Medicare plus maybe Medicaid. I think there's going to be extreme opposition if you're going to drop off Medicare when this goes forward. I would like to have the governance board, whenever you're discussing things, especially those that are going to go to vote, to automatically refer yourselves to 751 or 751, and especially in the area of values and principles. One of the values is that regardless of wealth and income, we will be covered. So these proposals go in direct opposition, I feel, that ORS 751 establishes. As far as, I really like Jamie's comments on, all that. I think it's really a good idea to look at malpractice. This is one of the phenomenons in the US industry that I think curtail good care. And if the state could cover that, that would be great. As far as payment, I'm sorry I'm going over time, but you've covered a lot of things. Congratulations in this meeting. I find that it will create opposition to take payment away from specialists. But I do see the need for primary care. So if we could establish, a payment schedule based on a logical percentage decrease, taking in consideration the savings of administration on every doctor's office, and then pay primary care more. That would be my recommendation. And thank you for letting me go over time.
Oh, I think you're on mute, Helen. Sorry.
My dog was barking. So yeah, thank you, Lou. Appreciate that. And then thank you to all the committee members for being here today and for all your thoughtful contributions. We really appreciate your time. We will see you in February. Thank you.